welcome to the 2021 UNC Water and Health Conference, and thank you for joining our session. I'm Allison Lee. I'm from the Water Institute at UNC, and I'm the room host today. Just a warning before we proceed, it seems that there are some technical difficulties, and some of the presenters may have delays in showing slides, and I may be one of them. So if it seems like I've advanced, but my slides haven't, give it a couple seconds. Before we get started with our presentations, I have a few announcements to share. First, we have networking events for the day. Join us later on Remo this afternoon to connect with colleagues and sponsors alike. Please note that you will need to make an account on Remo, but our instructions on the website will help you do so. For our participants around the world who can't make it to live sessions, join us tomorrow morning for a recap of today's events. The late early show will discuss how to apply today's lessons to regions of Africa. Now, this session is being recorded for folks who cannot attend the live session. Just a reminder, throughout the presentation, you'll find that the chat feature on Zoom is disabled and everyone but the verbal presenters have been muted. Please direct all questions and comments to the chat tab when possible. This tab will save for viewers who want to watch the recording at a later time. And it can also help presenters respond to questions along the way. And finally, we would like to thank our sponsors. We would not be able to do this without your support. And in particular, we would like to thank Easy Water for Everyone, DT Global, and the International Association of Plumbing and Mechanical Officials. Now that our announcements are complete, we're excited to proceed to our verbal presentations. Our presenters for this session are Dr. Laura Brown from the London School of Hygiene and Tropical Medicine, Victoria Cuellar, MPH from the Desert Research Institute, and Dr. Sarah Young from Northwestern University. They'll be sharing their work on water treatment, water sustainability, and water insecurity. We're excited for our presentations today. So to get us started is Dr. Laura Brown from the London School of Hygiene and Tropical Medicine. Stop sharing my screen. So whenever you're ready, yeah.
Great, can you see that? Good. Great. Right. So good morning, good afternoon, everyone. My name's Laura Brown, and I'm from the London School of Hygiene and Tropical Medicine. And today I'll be presenting research from water treatment for schistosomiasis control. So for those less familiar with schistosomiasis, it is a water-based parasitic disease that is classified by the WHO as a neglected tropical disease. And it affects approximately 200 million people worldwide, making it the second most common parasitic disease after malaria. It leads to approximately 200,000 deaths every year, primarily in sub-Saharan Africa, as you can see in that map. The research I'm presenting today was part of the WISER project, which stands for Water Infrastructure for Schistosomiasis Endemic Regions. And one of the project's objectives was to determine how effective different water treatment processes are against the parasite that leads to schistosomiasis. And we looked at 4 different treatment processes, but in today's talk, I will be focusing on chlorination. Schistosomiasis is a disease that's contracted through contact with fresh water that contains Secari. And these Secari penetrate the human host skin to develop into adult worms, which in turn lead to chronic ill health, including anemia, diarrhea, as well as organ damage. The worms then produce eggs, which are released through the feces, and if they reach fresh water, they hatch and go on to infect snails. And these then start to produce Secari, which penetrate the human host skin. So it's really important to note that this disease is not contracted through drinking water, but simply by being in contact with contaminated water. Looking at the life cycle, we can also identify ways to cut transmission. And the most common way is through mass drug administration with the drug Quintiles, which is relatively effective, but it of course does not prevent reinfection. Sanitation can be used to reduce the number of eggs entering the environment, and snail control has been applied to reduce the number of snails in the environment. But to reduce infection, you really have to reduce contact with water that contains Secari. And this is, of course, hugely challenging because communities often rely on freshwater bodies for household and recreational activities. But one way that you could potentially achieve this is through water treatment. So when we talk about water treatment, we don't intend to treat entire lakes or rivers, but instead water is abstracted and then treated on a household or community scale, where it's then provided through water infrastructure, such as bathing or laundry stations. And by treating water, we don't just provide communities with clean water, but we also reduce the time that's spent at transmission sites, which further can reduce reinfection. Just to quickly give you an idea of what the snails look like, this is one species, and when they're exposed to light and temperature, they start to produce these Secari, which are these little white lines here. And this is an image of Secari penetrating the skin. They're around 500 microns in length and can survive up to 3 days in the natural environment. And so when we talk about water treatment, the aim is really to inactivate or remove the Secari from water. So when we started with this research, we tried to find out how to produce safe Secari-free water. Essentially, if you collect water from a transmission site, how would you make that water safe? And we looked at several recommendations, but these only really stated boiling water as a means for treating water that's infected with Secari. So we then tried to answer this question by conducting a systematic review, but the results really showed huge variability for all the treatment methods that we looked at. And because of this, we concluded that there was both insufficient but also incoherent data to develop guidelines. And that was really the reason why we went ahead to conduct experiments. So for all of our experiments, we used Schistosoma mansoni Secari. And these were produced by extracting eggs from infected mouse livers, which we then exposed to snails and then produced Secari. Most of our experiments were conducted at the Natural History Museum in London using these lab-grown Secari, but we did also replicate experiments in Tanzania using snails collected from a transmission site. And this was to see if the lab-grown and the natural, I guess, wild Secari were equally sensitive to chlorine. For the experiments, we used water that was controlled at various temperature and pHs. We added the Secari, dosed chloride in the form of sodium hypochlorite, and then ran experiments in 5-minute increments up to 45 minutes. At the end of the experiment, we measured the viability by counting the number of live and dead Secari, and finally measured the residual chlorine. Just to give you an idea of what it looks like when you inactivate Secari. So this video shows initially how they're very fast moving, they're swimming at the top of the surface. Then when you dose chlorine, they sink to the bottom of the beaker. Their movement really slows down. And we consider the Secari to be completely inactive when they have completely stopped moving, as shown in this last part of the video here. So we ran approximately 600 individual experiments, which are really summarized in these two graphs here. So the graphs show the CT value that is required to inactivate Secari at a given log inactivation. And a CT value is the product of the chlorine that's available for disinfection and the contact time. So it's essentially a measure for how long an organism has been exposed to a certain concentration of chlorine. And this first graph is for 20 degrees, the second for 27 degrees, and you've got the 3 lines for the different pHs. And what these graphs really show is that chlorination is a lot more effective at high temperature and lower pH, which would be expected because of the chemical reaction of chlorination. I don't want to spend too much time on these graphs, but they're really just to show that we use them to read off the CT values at given log inactivations to produce what we call a CT table. And so to produce design recommendations, we read off the highest, most conservative CT value, which in this case is 26 milligram minutes per liter. So this was for laboratory-based results, but as I said, we did also replicate these experiments in Tanzania by collecting water and snails from this transmission site. And although you can't directly compare the results to the lab results because we didn't control for the pH and temperature, the results do show that the results from Tanzania are in line with the laboratory results, and we confirmed this with statistical analysis. So in terms of guidelines, our raw results showed that a CT value of 26 milligram minutes per liter is required to achieve a 2 log inactivation under our worst case condition. And we then applied a measure of uncertainty, which brings our recommended value to a CT of 30 milligram minutes per liter. And this is in fact the value that's going to be included in the WHO schistosomiasis fact sheet. Just as an example, a CT of 30 milligram minutes per liter can be achieved with a chlorine residual of 1 milligram per liter after 30 minutes contact time. So in conclusion, we have tested the effectiveness of chlorine against Schistosoma mannsoni sakari and found that they are relatively sensitive to chlorine, requiring a CT of 30 milligram minutes per liter to achieve a 2 log inactivation. Now, this research has really answered some of the technical questions on how to inactivate sakari using chlorine, but I really think that the bigger challenge will be finding ways to implement these guidelines sustainably in communities, whether that is through laundry stations or showers. And also just important to note that whatever the solution is, it will definitely have to be very context specific. The last point I want to make is that we really don't see water treatment as being a standalone control measure, but rather that it gets integrated into existing control programs, because that way the overall disease burden is reduced through drug administration with praziquantel, and reinfection is slowed due to reduced contact with sakari contaminated water. I'd like to thank the entire WISER team, especially Meseret, Mulderwork, and Jacinta, who helped lead a lot of this research. Thank you very much.
Thank you, Dr. Braun, for your presentation. This is some very exciting and important work that you're doing. If anyone has any questions, please put them into the chat tab.
Perhaps while we're waiting for questions, I just want to say that we have recently published this work about chlorination in PLOS NTD. And in the past 2 months, colleagues have also published a paper about the effectiveness of sand filtration against Schistosoma sakari, as well as UV disinfection. So if anyone's interested in that, that is available on PLOS NTD.
That's really exciting. Thank you for sharing. If you want to put the link to that into the chat later, I'm sure people will enjoy that. There is a question asking, I'm trying to understand, how does the 1 milligram compare to what would normally be used for drinking water treatment?
Yeah, so generally when we talk about chlorination, we always talk about a CT value. So it's the residual chlorine as well as the contact time. So generally, if we're comparing it to CT value of 30 milligram minutes per liter is considered medium sensitivity by the WHO. And I think actually a CT of 30 milligram per minute per liter is generally also suggested for treating drinking water. I think I've got a slide here which shows how the CT value compares to other pathogens. So you can see that sakari are more sensitive than cholera, but less sensitive than E. coli, for example.
Thank you for your response for that. There is another question. I think this will be the last one we'll have time for now. But if you have further questions, please feel free to put them in the chat. Have you looked at CT in different turbidity levels?
Yeah, so all the experiments that we ran at the Natural History Museum were using bottled water. And then the experiments that we ran in Tanzania, you used natural water. So we did record the turbidity for that. And we actually found that it didn't heavily affect the results, because although you need to dose more chlorine into the water if it's more turbid, the residual chlorine should in theory be the same that is required to inactivate Sakari. And that's why we always talk about a CT value, because it's the residual chlorine that we're looking at, not the dose of chlorine.
Great, thank you so much for your responses. If you have any further questions, please feel free to put them in the chat tab, but Dr. Braun, thank you so much for your time. Next up, we have Victoria Cuellar, MPH with the Desert Research Institute. Victoria, please share your screen and begin your presentation.
Yeah, thank you. Oh, there we go. All right. Hello, everyone. As mentioned, my name is Victoria Cuellar, and I am here on behalf of the Desert Research Institute's Center for International Water and Sustainability, and here to present on the project that we have on building long-term sustainability of WASH in healthcare facilities. So before we delve into what exactly it is that we're doing, we just want to do a quick overview of what the current state of WASH is in healthcare facilities. Approximately 2 billion people visit healthcare facilities that lack basic water services. 1.5 billion visit facilities that lack any sanitation services. And every year, 17 million women give birth in healthcare facilities with inadequate WASH. This last one really blows my mind because I just had a baby 4 weeks ago. And so to think that I would have to worry about something other than my baby being healthy really blows my mind. And so this work is really near and dear to my heart. And so, yeah, let's dive into it. So when we talk about WASH in healthcare facilities, what exactly are we talking about? Well, we're talking about it's water from an improved source. It's sanitation and how we think of sanitation normally with toilets, latrines, making sure that we're keeping humans separated from human waste. But also we're talking about healthcare waste management, and that includes sharps and infectious waste. So anything that might result from an operation, from giving someone a shot, all of those things that we wouldn't normally think about in a community household setting. And then hygiene, it's not just personal menstrual hygiene or hand hygiene, but also how do we take these things and get them to prevent infection and control infection, environmental cleaning, making sure that that bed that you were lying on is clean and was sanitized between you and the last person who used it, and then that'll be sanitized for the next person. All those high contact spots where those doctors are coming in and out, those nurses touching things and then going in and touching you. And also equipment processing. So making sure that things are being sterilized the way they should before being used between one person and another. And the really big thing to highlight here is that we want these aspects to be sustainable, climate resilient. I mean, we all know that we're seeing the effects of climate change all over the world. And it includes that common infrastructure, resources, services, and practices in that healthcare setting. So why is this that important? Well, the chain of infection looks really different in a healthcare setting than it does at the household, because you are bringing a lot of susceptible people together with common people between them. So those doctors and nurses and other staff that are coming and going. And you have a lot of visitors. So it's a lot of people in one place with lots of points of contact. And you have folks who are susceptible. So sick people, newborns, all of those things. And so what can we do? Well, clean drinking water is important. So being able to take your medication without getting a stomach bug. Clean and sterilized equipment between uses, between people. Making sure floors and surfaces are clean. That hand hygiene with water, soap, alcohol rub. I remember I've been in and out of lots of clinics with being pregnant, and doctors, there's always a hand sanitizer as soon as you walk into a patient room. And you always see people use it when they walk in and when they walk out. So having those cues and having those things available so you can do them. And then again, management of that healthcare waste and human waste, making sure that people in the community or animals aren't getting into it as well. So in 2019, we did a pilot assessment of 18 healthcare facilities in Rumfi, Malawi. This is a district in northern Malawi. We looked at wash service levels and the sustainability factors. So, are these things going to be able to sustain themselves over time is what we looked at. We interviewed district staff, facility staff, patients to get their sense of what they were seeing when they go in and get healthcare provided to them. And so we partnered with the Rumfi district leadership. And by saying we partnered, I mean the Desert Research Institute, Transform International, and then our local partner in country, DAMRA. So we created this partnership. So what came of this? Well, we found out that, surprise, lack of continuous water service from safe services. So they weren't getting safe water. Inconsistent water treatment practices. Some places were doing things, some places weren't, or they weren't doing it consistently, and there was no water quality testing. As far as sanitation, there was poor accessibility. And that includes folks who, like myself, being very pregnant, you can't go into a tiny stall, or if you're in a wheelchair, or if you're on crutches, those sorts of things that we have to think about. Lack of gender and staff patient separation. So there weren't restrooms designated for one group or another, or even just by gender. There were no menstrual hygiene facilities, and the available toilets weren't always functional. So what do visitors, staff, and patients do? As far as hand hygiene, there were insufficient hand hygiene facilities, and they were often far from toilets. So again, if there's a big gap between the toilet and your hand washing facility, chances are you're going to get intercepted somewhere in between, and you're not going to make it to wash your hands. Water alcohol rub was often available, but sometimes not close to the points of care. So again, mentioning that in all the doctor's offices that I was in while pregnant, there was always something as soon as you walked in the room. So it was that mental trigger to always use it. And if it's not there, then, no one was going to use it, right? Waste management is a big one. So inconsistent segregation and disposal practices. So again, being in the hospital, there was a red bag for bodily fluids. There was a sharps container. The blue bag was laundry. And then there was a regular trash bag. So again, being able to separate those things. And if you're not separating them, then you're not knowing how to dispose of them properly. Lack of functional or environmentally safe incinerators. So a lot of the incinerators that we saw either weren't built to specifications, meaning that they were creating pollution for the surrounding areas, or they weren't properly incinerating and destroying the waste that was being put in there. And so again, that poses a threat for the surrounding community and any animals or livestock that might get in there. And there was a lack of capacity around operation of these incinerators. So again, the folks running them didn't necessarily have the training that they needed to properly dispose of that waste or how to handle it safely. And then environmental cleaning, there really weren't any cleaning guidelines that we could see. There really wasn't any training that we had seen by the cleaning staff. There was a lack of an accountability mechanism. We've all been in restrooms where you see the date, the time, and the person who signed cleaning that restroom. Well, these sorts of things weren't present. So you really don't know when the last time was that it was cleaned, if it had been cleaned, and who cleaned it. And cleaners' roles weren't valued. And that's an issue that we see here right now at our airport here in Denver. We're seeing a big strike by the cleaning staff because again, they're not being valued. So these were the things that we were seeing that were contributing to these healthcare facilities not offering the best possible healthcare. So before I go into what we decided would be a good solution and this was with the district and in conjunction with all of our stakeholders, I'm going to go into what the circuit rider model is real quick. So it's a group of qualified traveling technicians that have been trained. They visit a certain number of communities 20 to 40 times a year. 20 to 40 systems 4 to 6 times over the course of a year. And these are regularly scheduled maintenance calls. So they're going to make sure that there's not necessarily a problem, but just checking in. And of course, they're available for any issues that might pop up. They're providing assistance, not just on how to repair things, but also how to balance the books, how to make sure that they're saving enough money for that next set of repairs that they're going to need to do. They're providing capacity to those local water boards. I'm sorry, 5 minutes?
2 minutes.
Oh, okay. And they're focusing on preventative maintenance and life cycle costing. So things that are going to be needed down the line. So we came up with streams. So training, empowerment, and monitoring support. And so this is the circuit rider program that we came up with. And so basically we separated into two types of circuit riders. So there's the climate change, the guys who are doing the water and sanitation and that waste management. And then there's the quality of care circuit rider. And they're the ones who are really going to help those folks figure out how to do that prevention control, the hygiene waste, and ensure guidelines and that everything's in place for them to do their jobs. So one important thing to note is that the role of local government, it's there. We didn't replace anything. We're working within what's already there and within the mandates of the district office. And we're working in conjunction with communities because a lot of the water systems aren't just for the health system, but they're also for the community. So how do we work with them to make sure these are functioning optimally? And then the big thing about streams is that we really want to make sure that we're evaluating our program correctly. So we're improving that sustainability of infrastructure, that downtime. Are we actually helping with plans and future costs? Are we assisting staff with getting those behaviors that we really want? Are we providing sustainable availability, access, and effective utilization of WASH by men, women, boys, and girls? Are we being cost effective? And there's also a gender component. So we want to make sure that women and other genders are also taken into account and making sure that everyone is getting the care that they need. So this is a really big part of what we're wanting to do and something that is quite new to some of us in the WASH field. So what have we done so far? We did our official launch in June 2021. We've done a number of trainings, everything from district leadership and stakeholder orientations to introduction to the programs. We're incorporating WASH Fit for those quality of care technical circuit riders. And so they're the ones who are creating these teams within the healthcare facilities and making sure that, that these teams are in place so that they can put all of those water, sanitation, hygiene, infection control things in place while those circuit riders aren't there. We're doing hand washing training. We had a WHO consultant do a hand washing training for the folks who are working in these facilities. There was a big cleaning training, because again, it's not just as simple as going around and spritzing stuff. You have to know what to use where and why and when. We did a big solar powered mechanized pump training just recently. Just recently in September. And we're doing water quality sampling and analysis as well. So making sure that everyone has the tools that they need. So that way when our circuit riders go into these healthcare facilities, they have the tools to provide the capacity, the support, and also what to do with the data once they get it. The other thing is we're in the process of doing data collection and reporting. So we've done our baseline, and now we're collecting more data to see how we're doing. Do we need to do refresher trainings? Are we providing the information that we want and that we need to these folks? And so what else is underway? Well, like I mentioned, those WASH Fit teams are being set up at each healthcare facility, and they will be the folks who are sort of responsible for making sure that the day-to-day IPC and water and sanitation guidelines are being met. Our quality of care circuit riders are doing hand washing training and observation at the moment. So looking to see, what do people know? What are they doing? Where are the gaps that we need to identify? The circuit riders have started visiting their respective healthcare facilities. And right now, 6 water systems that we identified a while back that needed immediate repairs are being repaired now. And so there was one water system that had been down for 6 months and now it's functioning. So again, making sure that we are doing our part and that those circuit riders have the information that they need to do their work. And sort of the next step thing is going to be an expansion program into communities. So we're talking to communities in the district to see how do we expand this to those communities, because as I had mentioned, some of these water systems are not just providing water exclusively to that healthcare facility, but they also serve communities. And so how do we work together, because it's a joint responsibility. And so right now what we're doing is we're talking to communities, see, okay, well, what cost sharing can we do? We want to be able to train those folks maintaining those local water connections as well. So just a lot of, so that's our next step, is seeing how do we involve the community. So it's a comprehensive, holistic program. And so right there, I will go ahead and stop and see if there are any questions.
Thank you for your presentation and congratulations on your baby, by the way.
Oh, thanks.
There is a question in the chat asking, where does the funding for the circuit riders come from? Do you expect it to be sustainable?
Yes, so that's a great question. And yeah, and something that I sort of glossed over. Yeah, so right now we have funding for 2 years. And from the very beginning, so if I go up one more slide, this district leadership and stakeholder orientation that we had, the whole time we've been talking to the district and really making sure that they know that they can be advocates for this program. And we are working with them to incorporate this into their budget. And one of the issues that we've found is that often there is budget for water and sanitation, these sorts of things, but it gets seconded for other things that are immediate needs. So a big part of what we're doing is helping the district leadership also come up with their life cycle costing, so that way they can understand why it's important to make sure that this money stays in this savings account, because they're going to need to replace this big pump, or they're going to have to help do this big repair. So right now we have funding, and that's also why we are going to be going into communities, because we have to be able to cost share. We have to be able to make sure that the district is contributing something, the communities are contributing something, and that it's a shared cost amongst all. And again, that orientation was really to get the ball moving on, in 2 years, how do we shift this completely over to the district?
Thank you for your answer. If you have questions, please feel free to put them in the chat tab. We only have time for one more question, but Victoria, if you would be okay with answering the rest of the questions afterwards, that would be appreciated. So for our last question, another Victoria is asking, is being a circuit rider a full-time job, or is this work added on to people with other responsibilities?
Yeah, so again, something I glossed over because of time, and my apologies for that. Yeah, so these are people who are already part of the existing system. So the quality of care circuit riders, they already work within the environmental health department. They already work within the healthcare facilities. And so this is something that they're doing in addition to their activities, and they get a stipend for it. And we've budgeted that they'll be doing about 5 days of work a month. And same goes for the technical circuit riders, the guys doing the more wash specific stuff, as far as repairs and maintenance. They already work for the Water Users Association. They are a part of that system. And so these are things that they already know how to do, and they're getting additional training. And again, about 5 days of work each month. And so things are a little slow at the beginning, because with the trainings, a lot of times the training are those 5 days that they have. But now they're really getting into the meat of the program and going out and visiting those healthcare facilities.
That's fantastic. Thank you so much for your presentation. You have a couple questions in the chat tab on Pathful, so definitely give them a look over if you have time. And if you have further questions, you can also add them in there. Thank you so much. And next up, we have Dr. Sarah Young with Northwestern University. So Dr. Young, it is your turn. Take it away.
Hi, thanks. Can everyone hear me? Allison isn't saying there's a problem, so I'm going to get started. It's a pleasure to be here today with you to discuss experiences of water insecurity in half the world's population. Is it? Can I advance? Yes. Now let me orient you to the concept of experiences. So oftentimes when we talk about water, there are different ways of measuring it. And sometimes we talk about availability, and sometimes we talk about physical accessibility or infrastructure. Sometimes we talk about safety. But these experiential measures are holistic indicators that capture access, acceptability and use, and stability across time. And because they're predicated on availability, it indirectly measures availability. There are a number of great experiential measures to measure kind of experiences in specific settings. There's a great one for Ethiopia, Kenya, etc. But what we wanted to do is to measure these concepts in a comparable and cross-culturally validated way. So we developed the water insecurity experiences scales. Now, some of sometimes people say experiential measures. I don't know, I would feel better if they were objective. But people make decisions based on what they see and do. And, you know, most of my work has been in Kenya. In Kenya, people may know that there's plenty of fresh water per capita if you take Lake Victoria and divide it across the population. But this very pregnant woman on the left carrying water up a rocky hill, it doesn't change what her experiences are, or this woman who's queuing for a long time to get water for her family. So I'm a firm believer in the value of quantifying people's experiences. And if you don't believe me, I can tell you that food insecurity experiences are the basis of SDG 2. I mean, every year, the food security and nutrition in the world that comes out, and that's based on the food insecurity experiences scale. So you can kind of think of the WISE scales as a sister scale to the brother food security scale. So what we did was, and if you click on that QR code, it will take you to the website to give you some of the background, but we identified 12 universal experiences with water, and it's these 12. And each of these items, you ask, how often have you worried about water, had to change the food you prepare because of problems with water, been angry about your water situation? And those are scored from never, if you never have that, to often or always if you are, such that the range is 0 to 36. We also set a cutoff of 12 or greater as being water insecure. These can be measured at the household level, and that is published. You can measure this at the individual level, and that gets at a little bit more of a gender disaggregated or disaggregated by other sociodemographics, and that paper is coming out tomorrow. There's also a short version that's been really handy for phone interviews. So those are the flavors of the WISE scales, and they all are valid, equivalent, reliable, and brief, and the validity has been tested in low and middle income countries, and it's looking pretty good for high income countries too. So happily, these scales have been implemented in 48 countries by more than 100 organizations and counting, including USAID, Oxfam. It's being trialed in the mix by UNICEF, and some of you who are in the audience, I see, have also used this. And that's great. And I think about when we want to get a new indicator into the lexicon, you sort of want to do a bottom-up approach and also top-down, so we see what it looks like at a national level. And so I partnered with Gallup, who does excellent nationally representative sampling, and UNESCO, the scientific arm of the UN. And last year, we collected data to estimate water insecurity in 31 low and middle income countries. And we did this with the iWise scale, the individual version of the WISE scales. And that's what I'm going to show you today. This is sort of some of the first glimpses of what this looked like. I'm going to talk first about what the prevalence looks like. So as with most scales like this, the darker the data, the higher the prevalence. So you can see that China had some of the lowest prevalence. And remember, the score is, water insecurity is assessed if you score 12 or greater. And this is a sample of about 45,000 people, and it represents roughly 3 billion people. So there's lots more to say about this, but this is sort of just a quick glimpse. And with this information, we're starting to get a little bit of a different picture than what other water indicators would lead us to believe. So Brazil, for example, it has some of the most water, fresh water per capita in the world, but 16% of those people in Brazil are experiencing water insecurity. Also, according to JMP data, both Brazil and Egypt have near universal coverage of improved water services, but you can see, for example, that a quarter of Egyptians are experiencing water insecurity. What are the most common water insecurity experiences? So along the bottom, you're seeing the 12 iWise items, and along the left-hand side, you're seeing the proportion of respondents who experienced those, either in yellow, 1 or 2 months in the last year, up to in red, almost all of the months in the last year. And interruption is the most commonly experienced, but worry and anger are also quite common. There's lots more to say about this too. I'm going to just talk briefly now about how water insecurity varied by country level indicators. And for those two, I'll talk about availability. So freshwater availability and infrastructure. So what you're seeing here along the bottom is the total meters per capita log transformed for renewable water resources. And along this axis, the left axis, you see the proportion of the population who are water insecure. And what this tells you is that there's not a strong relationship. National water availability does not predict the proportion of people who are water insecure. I was very interested to know how infrastructure shaped or changed with, or how water insecurity was associated with infrastructure. And we see there's a stronger relationship here. The larger the coverage of basic water services, the lower the proportion who are water insecure. But there's a lot of other things going on. This is far from a one-to-one relationship. Also more to say about that. But finally, I'm going to look at some of the individual level characteristics by water insecurity. And this is where the sort of the beauty, I think, of the IY scale shines, is that we can finally see how there are differences in individual characteristics. So first off, gender. Now this is a roughly 45,000 people. And when these values are adjusted for the weighting that you need to do for such large surveys. But what you see is roughly 13% of men are water insecure and 15% of women are. And that's not different. And I was really surprised by that. When we look at this relationship in adjusted models, so we put all the stuff in that you need that we could with the data that we had, we see overall that there's not a difference in gender, in water insecurity by gender, but that you see in some places, women are scoring lower than men in terms of water insecurity. So women are less water insecure in these countries up top. But meanwhile, they're more water insecure in these countries at the bottom, Cameroon, Algeria, Guatemala, Senegal. I was surprised. Looking at it by urban and rural, you see that there are, we can kind of expect that maybe there would be more water insecurity in rural settings, but not by a lot. And that's just in a straight up bivariate analysis. But when we look at the adjusted model, overall, there's not a big difference. But when we look at it by country, then the picture changes. So in Namibia, rural people are more likely to be water insecure. The mean score is higher, and in all of these countries at the bottom. But meanwhile, it's urban people who are more water insecure in these countries at the top. Lastly, how does water insecurity shake out by income quintiles? So these are so dividing income into 5 groups. This is the poorest of the lowest income. And here are the people with the highest income. Now, kind of as expected, water insecurity goes down as income goes up, but it doesn't go away, not even in the highest income quintile. And what you can see is that pretty much generally the richest quintile, so this is in yellow is the richest quintile, and in red you see the poorest, that generally the yellow, the wealthiest people are the least, have lower water insecurity scores. But there are some anomalies. I hope my Zoom thing isn't blocking this. So like in Honduras and Zambia, it's flipped. Why is that? I don't know. I'm intrigued. So we have lots of work ahead of us, but just to kind of a couple of takeaways. If you weren't listening up until now, listen up. We know that the individual water insecurity experiences scale. It's reliable, it's equivalent, so you can compare these scores across settings, and it's valid in low and middle income countries. We know that current water indicators correlate with water insecurity, but they can underestimate the number who experience problems with water insecurity. And you saw that, for example, in Brazil and Egypt. It always helps to identify who within countries is most in need of improved water security. And that picture we're finding to be I'm finding it to be surprising. But then lastly, I would say the take home is that we should be capturing nationally representative data on water insecurity experiences in every country. So in 2020, we measured water insecurity in 31 countries. And my goal, and I'll say this to anyone who will listen, is that we need to be doing this and getting nationally representative data in all countries, because how can we be making decisions about improving water security if we don't know who's being left behind? We need this for robust decision-making. So with that, I want to thank the funders. I want to thank my collaborators, and especially Dr. Bethencourt, who I think is on this call and can answer all your hard statistical questions. Thank you so much.
Thank you so much, Dr. Young, for your great presentation. If anyone has any further questions, please feel free to put them on the chat tab on Passable. Currently, you have one comment saying big fan of this work. Great presentation on that. While people might be typing in questions, what is an application that you hope to find? What is an application you hope to apply the IY scale to moving forward? You mentioned a couple, but what are some of the areas that you're really interested in?
Allison, I'm sorry, you broke up a little bit. Can you repeat the question, please?
Oh, I'm so sorry. What's an area of, what's an application area for the IY scale that you're excited to continue investigating?
Oh, so many. So, I mean, I think it's really interesting to understand what the prevalence is. For example, I think we're way underestimating what the prevalence of water insecurity is in high income countries. We should know that. But one of the really handy uses that we've seen, like Oxfam has been an early adopter, is measuring a water insecurity before an intervention happens and then after an intervention happens. So we can see, A, if there was an impact, sometimes there's not, when we want there to be, B, how big that impact was. And then with that, we can calculate, for example, return on investment, or how wise that investment was. The other thing I would really like to spend more intellectual time on is understanding how water insecurity manifests in people's health. So like with food insecurity, we used to think that food insecurity was just a nutritional problem, but we know that food insecurity predicts depression, poor school performance, suicide tendencies, suicide risk. I mean, these really far-reaching consequences. And I suspect the same is true with water insecurity. We just haven't yet been able to quantify experiences. So I hope that, I'm sure that that's an area for discovery in the next few years.
Much. You have a couple questions. The first in the chat is, have you had much traction with governments in terms of their use of the scale?
Yes, so happily, I'm so delighted. The Mexican government has taken this up for their National Health and Nutrition Survey. So that's going on right now. We'll have those data by January. And that's great because, I mean, Gallup is wonderful because that gives us really great prevalence data, but we don't have information on child growth or dietary diversity, et cetera. The US government has recently decided to have their Feed the Future countries use this in zones of influence surveys. So that's going to be super interesting. And then I don't know if you call IFPRI, it's government adjacent, but IFPRI has implemented this in 7 or 8 countries in repeated measures. And Josh Miller, a UNC PhD grad student, is analyzing those data to look at how food insecurity is dietary diversity, hunger, and illness are co-varying with water insecurity.
Great, thank you so much. Another question is, what is your current plan for reaching all countries?
Yeah, so fortunately, Gallup has a wonderful infrastructure for collecting data in 150 of the 180 countries of the world. I just need a few more $100,000 to be able to afford that. So we have some funding lined up, but I'm doing a song and dance, tap dance to anyone who will listen, because these data I think will be, imagine having a state of the world's water insecurity report that parallels the state of the world's food insecurity. Those aren't data I can collect myself, no matter how good my research assistants are, but with, partnering with Gallup, we can do that.
Along those lines, someone is asking, what opportunities might there be to assess the U.S.? American Community Survey, American Housing Survey, how can we get on the agenda?
I am open to any ideas. So call me, whoever that, that person is asking the question. I mean, Gallup would be another mechanism for doing that, but certainly there's a lot of different ways. I mean, NHANES comes to mind as well. They have some really interesting drinking water questions in there. Asher Rossinger has done a great job analyzing those data. But drinking water questions are a proxy for water insecurity. They don't capture the holistic experiences of water insecurity.
Great. Since you're doing okay with time, we can do a couple more. There's a question, any plans to look at seasonality? Can you create within country heat maps to identify areas of greatest risk? May also be useful to consider applications related to climate. So I am sure you are on.
Yeah, so I think that water insecurity is climate change made manifest. And there's a lot of opportunity for understanding how climate is shaping water, and water insecurity is shaped by climate. In the iWise data, what we did was we measured, the recall period was 1 year because the purpose of that particular study was assessing prevalence. But in other studies, we've measured water insecurity concurrent with food insecurity every 3 months so that we could see, and this was in Western Kenya, so that we could see how water insecurity changed by season, but also how it co-varied with food insecurity. And we found, as expected, but it was the first evidence, so I don't know if I expected it or not, but we saw there that water insecurity predicted subsequent food insecurity. So yes, we can use it to look at seasonality. You should definitely have carefully thought through your recall period if you want to do that.
And then what will be our last question for the session? How did Gallup collect this data? Was it through household visits or phone survey?
Yeah, so the plan was to do household visits, and the original plan was to do only Africa, North Africa and Sub-Saharan Africa. Insert COVID, so they pivoted to telephone, and with telephone, we could only work in countries with enough telephone penetration so that we could get nationally representative data. So we removed some of the countries in Africa that we had planned, and happily now have these data from like Brazil and China and India, Bangladesh, Honduras, Guatemala, Brazil instead. So these were all phone surveys this year.
Great, thank you so much. If you have any further questions for any of our presenters, feel free to add them to the chat or message them. I believe that's an option on Passable. Thank you, Dr. Yang, for your presentation. Spotlight and continue to share screens to wrap up the session. So just some reminders for the rest of the day. We have networking events following the poster session. So we have networking events at 3:30 today, Eastern Standard Time on Remo. They're great opportunities to connect with colleagues and sponsors. And then we have the late early show tomorrow morning, particularly for people in different time zones who can't make it to the live sessions. This is a great opportunity. Tomorrow they'll discuss how to apply today's lessons for Africa. Thank you guys so much for using the chat tab. If you have any questions or want to refer back to another comment that was asked, feel free to use the chat tab. And this meeting will be recorded or is being recorded and will be posted on the site as well shortly after. Well, maybe not shortly after. Maybe let's give it a day. But we couldn't do this without our sponsors. So thank you once again to Easy Water for Everyone, UC Global, and IATM. We're very grateful. And big round of applause to all of our presenters. You guys did a fantastic job, and I learned so much from all of your guys' incredible work. So, thank you, and that concludes